Good morning everyone. So today we are going to discuss a different topic from the point of ECG. So we are going to discuss ECG predictors of sudden cardiac death. I am Dr. Gunjan Shah. I am currently assistant professor in the Department of Cardiology at UNMICRC Institute of Cardiology. So sudden cardiac death is defined as the death which is presumed to be of a cardiac cause that occurs within 1 hour of onset of the cardiac symptoms or within 24 hours of last being seen healthy or alive, which is responsible for approximately 10% of total global mortality and 50% of total cardiovascular death. The worldwide incidence of sudden cardiac death is around 55 deaths per 1 lakh patient years, and approximate estimated survival of out of hospital cardiac arrest is only less than 10%. So consider that more than 90% of them are fatal if any patient has out of hospital cardiac arrest. According to a US study, sudden cardiac arrest has been divided into a shockable rhythm, which is ventricular tachycardia or ventricular fibrillation, and a non-shockable rhythm, which is pulseless electrical activity or asystole. Out of all these sudden cardiac arrests, out of all the total patients, 1/3 patients have documented shockable rhythm in the available EMR ECGs, and out of this 1/3 total patients, majority means 93% of the patient has ventricular tachycardia, and rest only 7% patients have ventricular fibrillation. This is the epidemiology which was published in a 2018 Arrhythmia and Electrophysiology Review journal, which shows that majority of the patient responsible for sudden cardiac death has either high risk cardiovascular risk factors or any prior cardiovascular event. As you can see on the right side of the graph, that the second and third amounts to majority of the total burden of sudden cardiac death, and the next follows patient with severe LV dysfunction of any etiology, whether ischemic cardiomyopathy or dilated cardiomyopathy, and another subgroup which consists either idiopathic ventricular fibrillation or any channelopathies, hereditary disorders, which has a highest incidence in sudden cardiac death but relatively low total prevalence in the sudden cardiac death burden. So heart disease is a major cause of death in industrialized nation, which approximately 50% of the death attributable to sudden cardiac arrest. Total approximately 3 lakh patients suffer through sudden cardiac death in US. The number for India is much larger than that. Approximately 10 lakh patients per year in India develops sudden cardiac death or has an episode of sudden cardiac arrest, which is I would say that less than what is actually the data is. The reported data must be less than that. Till this time, no individual ECG finding has been found to be able to adequately stratify patients with regard to risk for sudden cardiac arrest. However, one or more of these candidate surface ECG parameters may become useful component for future multifactorial risk stratification calculators. Several ECG based methods of risk stratification of sudden cardiac arrest have been studied, which includes QT interval prolongation, QRS duration, fragmented QRS complexes, early repolarization, Holter monitoring, heart rate variability, heart rate turbulence, signal average ECGs, T-wave alternance, and T-wave peak to T-wave end duration. These ECG findings have shown variable effectiveness as a screening tools. These ECG parameters are apart from what there is already defined ECG markers, which include channelopathies like Brugada syndrome, long QT syndrome, short QT syndrome, and WPW, which is not actually a channelopathy but considered a part of sudden cardiac arrest. Currently, risk stratification for primary prevention of sudden cardiac death is with an implantable cardioverter defibrillator, that is ICD, primarily relies on the reduced left ventricular ejection fraction, despite numerous other SCD risk markers with low individual predictive values identified. However, since relying only on severe LV dysfunction and low ejection fraction is not enough, as most sudden cardiac death victims have normal or only mildly reduced ejection fraction, combining several SCD risk markers, for example electrocardiographic parameters, into integrated risk models may potentially improve risk stratification and detection of those patients at high risk of a sudden cardiac arrest incident. Accordingly, several combination of ECG risk markers have been associated with a markedly increased risk for sudden cardiac death. We are going to look for the ECG patterns or ECG waves or rhythms which may directly denote that the patient is at a high risk of sudden cardiac death in a patient without any structural heart disease. Later on we will see that in a patient with structural heart disease which ECG parameters predict the prevalence or incidence of sudden cardiac arrest. So first is epsilon wave, which is a small deflection, a blip or wiggle at the end of the QRS, generally seen in V1 and V2 and can be seen up to V4, seen due to delayed activation of island of viable myocytes in a sea of fat. In ARVC, the right ventricular and to some extent in 10% of the cases left ventricular myocardium is replaced by fatty tissues. So there are viable myocyte islands and in between the sea of fatty tissues, which the activation of which leads to appearance of epsilon wave on ECGs, which is most characteristic and specific for arrhythmogenic right ventricular dysplasia, that is ARVD, but which is very less sensitive. Numerous studies have found to be a sensitivity of only 20 to 40% for detection of ARVC. There is something called Fontaine bipolar precordial leads, in which the lead 1, 2 and 3 are attached on a sternum. The lead 1 is attached on the manubrium of the sternum, lead 2 is attached at the Ziphy sternum, and lead 3 is attached in the fourth intercostal space in mid-clavicular line, which leads to enhanced detection of this atrial depolarization and this delayed activation of this island of viable myocyte. If there is no epsilon wave and there is clinical suspicion for ARVC, one may get Fontaine bipolar precordial leads to enhance the sensitivity of epsilon waves for detecting ARVC. By using these Fontaine bipolar leads, the sensitivity is increased to approximately 60% as compared to on an average 30% in general ECG surface electrocardiograms. These are some of the examples of epsilon wave in which you can see a small blip or wiggle at the end of the QRS. On the left upper image, there is a small positive reflection in V1. In left lower image, you can see that in V1, V2, V3, there is a smaller delayed activation wave which suggests epsilon wave in ARVC. And on the right side, there are basically three patterns of epsilon wave that has been described in the literature. One is wiggle waves, as you can see in the A section of right image. There is small upward spike or small downward spike in the B section of the right image, and there is a smaller deflection at the end of the QRS, which can be seen from V1 to V4 or V5 in at the end of the QRS, that is section C of the right image. As you know that the indication for ICD in ARVC patient or in any channelopathies or patient at risk of SCD foremost includes an aborted SCA or documented VT-VF or any strong family history of young SCD. That is class 1 indication for ICD implantation. One may consider ICD implantation in a patient if he has an unexplained syncope, but the probability of being the syncope of cardiovascular origin is less. Documented NSVT is in Holter monitoring or moderate systolic dysfunction of right ventricle or left ventricular, in which case ICD may still be considered. And in patients who are asymptomatic and are on genetic study being detected as a carrier, in that case patient may be closely followed up rather than upfront putting up the ICD. The second part consists of inherited channelopathies. Ion channel located in the cardiac cellular membrane are responsible for cardiac action potential. So when a genetic mutation results in abnormal functioning of this channel, a patient can be at risk for life-threatening arrhythmias. Considering that these abnormalities affect conduction, some of these abnormalities may be detected on resting ECGs such as Brugada, long QT or short QT syndrome, which we will see further on. Brugada syndrome is an autosomal dominant sudden death syndrome related to the mutation of the sodium channel that accounts for approximately 10 to 12% of the cases of SCD, which is a larger fraction of the SCD population, which is represented on the ECG as a curved ST segment elevation in anterior precordial leads, though some variation in morphology may occur in patient to patient or in same patient from time to time. The ECG patterns we will see later on. These events can occur during sleep or rest, especially during times of fever, as some of the channels which are mutated in Brugada syndrome are sodium temperature dependent, which may be activated, or the mutation may exacerbated in a patient who develops fever. Males have a higher frequency of arrhythmic events because of a sex specific effect on gene expression. These are the three types of Brugada patterns. Type 1, which is the most characteristic and pathognomic for Brugada pattern, is coved ST segment elevation of more than 2 mm in V1 and V2. The second pattern is Saddleback ST segment elevation of more than 2 mm, whereas the third pattern is intermediate of first and second pattern. So either coved or Saddleback ST segment elevation, but that is of less than 2 mm in amplitude. So Brugada syndrome will only be called, a patient will only be called of having Brugada syndrome if he has a characteristic type 1 ECG pattern along with either strong family history of sudden cardiac arrest or aborted SCD in the same patient. Otherwise the patient will be told of having Brugada pattern and not Brugada syndrome. Any of the Brugada pattern may be confused with enteroseptal MI. So the clinical context is very important. So a patient who presents with 2-hour onset of chest pain, perspiration or Gabramon or sudden onset dyspnea may be considered having enteroseptal MI. On the other hand, if the patient has 1 to 2 days history of infection or diarrhea or URTI or LRTI, and with the pattern of type 1 or type 2 pattern, the patient may be thoroughly investigated and history taking should be detailed to rule out Brugada pattern rather than upfront treating the patient for SCS. In past, we have seen that many patients have been thrombolyzed when the patients who had actually Brugada rather than enteroseptal MI. So clinical context and history taking becomes very important. The second is long QT syndrome. The most common channelopathy is estimated to occur in approximately 1 in 2500 people, putting them at risk for torsades and sudden cardiac death. The various subtype of long QT syndromes are encoded by different mutant genes, and there are almost more than 30 to 40 subtypes of long QT syndromes. For clinical importance, the three types of long QT syndrome, type 1, 2 and 3, is what matters the most. So the trigger for different types are different. So type 1 is generally triggered by swimming or any exercise. Type 2 is triggered by noise or alarms or any sudden large noise. And type 3 is generally characteristically seen in sleep, in which the patient during sleep develops bradycardia and predisposes to sudden cardiac arrest and VF. QT interval is not the only factor to diagnose LQTS. So any patient having corrected QT interval of more than 450 or 470 millisecond will not be of having QT syndrome. For that, we have to calculate Schwartz score to decide whether the patient has actually long QT syndrome or not. This is a very important figure which shows that approximately 15% to 20% of the normal population has QT interval, corrected QT interval less than between 440 to 480 milliseconds, whereas the patient having long QT syndromes, out of total patients, 30% patients may have corrected QT interval below 460, 470. So that is a very large number. So correct QT interval should not alone be taken into consideration before diagnosing the patient for long QT syndrome. There are three most common patterns for long QT syndrome. As you can see, long QT type 1 shows wide broad based T wave with a normal QT segment. The type which is most common, type 2, consists of a longer isoelectric ST segment and a T wave or biphasic T wave, and long QT3 consists of the longest isoelectric ST segment followed by a smaller upright T wave. So type 1 is the most common. The current mainstay of treatment for the most common type of long QT syndrome is beta blockade and avoidance of trigger for patients who suffer VT event. Despite beta blockade, and for patients with long QT types that do not tend to respond as well to beta blockers compared to other types, IC replacement should be recommended, but a first line of treatment should be beta blockers. If the VT or VF episode are there despite being on beta blocker, or you cannot uptitrate beta blocker, or patient is not tolerating beta blocker, then only you will consider ICD placement, because ICD implantation is only going to treat the VT-VF episodes, and the patient who will receive shock, there will be sympathetic stimulation. And in long QT syndrome, type 1 and type 2 sympathetic stimulation may lead to exacerbation of VTVF episodes. So ICD is not the mainstay of treatment and should not be considered in only as a single treatment. The third and last one is short QT syndrome, which is relatively very rare but most severe form of channelopathies. Most commonly first present as a sudden cardiac death occurring during rest, sleep or exertion from childhood to adulthood. It is diagnosed as patient having corrected QT interval of less than 330 milliseconds or less than 360 milliseconds with any of the following, including documented causative gene mutation, family history of short QT syndrome, family history of SCD in a young patient below 40 years, and prior VTVF episode that is otherwise unexplained and presumed to be of cardiac origin. This is the sample Ecg showing short QT syndrome. You can see that the patient has corrected QT interval below almost 300 milliseconds. So many studies were there, and it has been found that studies with total number of patients being studied close to 30,000 have found that there were no patient who had corrected QT interval below 300 milliseconds, and only 4% of the patient had QT interval being less than 330, and 20 to 30% of the patient had QT interval less than 360 milliseconds. Considering the severity of the short QT syndrome, contrary to long QT syndrome, the only recommended therapy for short QT syndrome is ICD placement, especially if the patient is a survivor of cardiac arrest or has a documented spontaneous sustained VT or without syncope. ICD placement should be considered in asymptomatic patient formally diagnosed with short QT syndrome, considering the severity of short QT syndrome. The next and last out of these patterns are early repolarization. Early repolarization is defined as elevation of the J point, the junction of the QRS complex and ST segment, by at least 0.1 millivolt in more than or equal to 2 contiguous inferior or lateral ECG leads. As you can see in the figure, there has to be more than 1 millivolt ST segment elevation in more than or equal to 2 contiguous inferior or lateral leads. New definition of early repolarization also include slurred QRS and downstroke without ST segment elevation, or J wave or J point elevation of more than 1 millivolt. Classically, it has been considered as a normal variant. Previously, it was thought to be of malignant was studied extensively, but now it has been found that only less than 1% of the patient of early repolarization develops sudden cardiac death or VTVF. So the potential role for finding this pattern as a prognostic marker for ventricular arrhythmia is low. Studies have shown that patients who had a documented SCD, so patient having J wave on ECG had a higher VF episodes compared to patient who did not have J wave or early repolarization, and increased incidence of ventricular fibrillation compared to healthy subjects was found in patients carrying early repolarization on ECGs, and higher prevalence of early repolarization pattern was also found in patients of sudden cardiac arrest in first degree relative of those patients. Studies have found that malignant early repolarization syndrome had more frequently J point elevation and terminal QRS slurring in inferior leads compared to lateral leads. So early repolarization in inferior leads should be emphasized more compared to lateral leads. WPW syndrome, it is not actually a channelopathy or hereditary syndrome, but is relatively common compared to other channelopathies, and is seen in 2 to 4% per thousand. So WPW is not a channelopathy or related to a known mutation, but to a presence of an accessory atrioventricular conduction pathways located outside of the normal conduction system. So because most such extranodal pathways lack decremental conduction properties, when the patient, especially when the patient develops AF, the ventricular conduction of the rapid atrial rate is very high, generally more than 300 beats per minute to the ventricles. So that is what mostly problematic. More than 300 rate of ventricular rate may lead to ventricular fibrillation and sudden cardiac death. An asymptomatic patient with classic finding of WPW, that is delta wave, short PR interval and wider QRS on resting ECG, has an annual sudden cardiac arrest risk of almost 0.1%, which is higher than the normal population, but compared to the prevalence of the WPW syndrome, those patients should be either upfront treated or risk stratified in a low and high risk patient. This is a sample ECG showing left lateral accessory pathway. In an asymptomatic patient, current American Heart Association guidelines recommend upfront ablation for all the accessory pathways. But in a scenario, Indian scenarios, the patient can be, particularly Indian scenarios, in which the patient can be divided in a low risk or high risk stratification based on pathway location, profession of the patient and properties of the pathway. But on the other hand, all the symptomatic patients who had either tachycardia, palpitation of history, documented supraventricular tachycardias, unexplained syncope or LV dysfunction which is related to the pre-acceleration should definitely undergo ablation. Fragmented QRS complexes are thought to represent conduction disarray caused by ventricular myocardial fibrosis or scarring, which is a very important substrate for development of VT-VF, sudden cardiac death. Fragmented QRS scoring system includes duration, amplitude and notching in 10 out of 12 leads, which excludes lead 3 and lead AVR. So the higher the score, the higher the chances of having a sudden cardiac arrest episode. So fragmented QRS ECG criteria include if the patient is a narrow QRS, then additional R wave which is R prime, notching in S wave or R wave, presence of more than one R wave or R prime in 2 contiguous leads. As you can see on the upper right ECGs, the patient is a narrow QRS, but either presence of an R prime, presence of more than or equal to one R prime in 2 contiguous leads, or notching in S or R wave will constitute fragmented QRS. Whereas in bundle branch morphology, there can be one notch for a typical bundle branch pattern. So more than or equal to 2 notches will be suspicion of fragmented QRS, or either multiple notches in R wave or more than or equal to 2 notches in nadir of S wave, as you can see in the right lower ECGs. So the proportion that we have seen till now, that includes Epsilon waves, Brugada syndrome, long QT syndrome, short QT syndromes, WPW and fragmented QRS can be there in a normal population, is mostly to be suspected when the patient does not have any structural heart disease and patient has an episode of SCA. The following parameters that ECG parameters that we will see holds true more often for patients with either previous ACS event or patient having LV dysfunction or high risk factors for coronary syndrome. So first of them is QRS duration. So QRS duration has been shown consistently to be associated with increased all-cause mortality. In one of the study, it was found that for every 10 millisecond increase in QRS duration, there was 1.3 times higher risk for SCD. And if the QRS duration is more than 110 milliseconds, then the patient is at 2.5 times higher SCD risk compared to the patient who has QRS of less than 95 milliseconds. But different studies have found conflicting evidence. So at present, to predict SCA by just based on only QRS duration is not a wise decision. But patient with wider QRS has found to be having at risk of higher all-cause mortality also. So that should be taken into account. The next one is QT prolongation. Slower QT interval represents ventricular repolarization. So QT prolongation will mean slower ventricular repolarization, and it indicates increased in temporal dispersion of the various ventricular region refractory period. As the QT prolongs, the vulnerable period for arrhythmia induction also prolongs, resulting in increased susceptibility to ventricular tachyarrhythmias. Evidence is conflicting regarding QT interval being independent predictor for SCD in post-MI patient. Two of the studies which had studied more than 700 patients did not show any direct relationship between QT interval and risk of VTVF. Another study which studied approximately 100 patients had showed direct correlation between QT interval and risk of SCDs. So at present the QT interval may be useful in some population but should not be taken as an isolated marker to predict or stratify patient for sudden cardiac arrest. Another parameter is QT interval, mean QT interval variable in 24-hour ECG monitoring. So a study was done in which studied almost close to 7,000 patients, in which they had seen put the patient on a 24-hour ECG monitoring, and so the mean QT interval, it was found that prolonged mean QT interval over 24 hours of more than 450 milliseconds or shortened mean QT interval of less than 400 milliseconds was found to be associated with a twofold increase of SCD, 2.3 for higher mean QT interval and 2.4 to be exact for lower mean QT interval compared to intermediate mean QT values, that is of between 400 to 440 over the period of 2 years. Holter monitoring is another factor in which you can stratify the patient for SCD. NSVT runs and high resting heart rate can stratify the patient for sudden cardiac arrest. So these two parameters are independently associated with ventricular arrhythmias. And those markers not only predict sudden cardiac arrest but also predict total all-cause mortality in general population. Another factor is short coupled VPCs. So short coupled VPCs in which the VPC is having a coupling interval of 260 millisecond plus or minus 30 millisecond will fall on the vulnerable period of ventricular repolarization and may precipitate torsades and VF. The next point is heart rate variability. Healthy individuals demonstrate considerable heart rate variability over time. Heart rate variability has been shown to be an index of parasympathetic function, and lower variability has been linked to increased risk of ventricular arrhythmia and mortality based on higher sympathetic function in those patients. So for example, in post-MI population, patient with low heart rate variability, SDN of less than 50 milliseconds, that is standard deviation of all normal RI intervals of less than 50 milliseconds, had a significantly higher 1 year mortality, 34% versus 9%, independent of LVEF. The only limitation is that the heart rate variability is affected by multiple factors including age, gender and drugs, and it cannot be considered in a patient with arrhythmias like atrial fibrillation or frequent ectopics, and it needs to be combined with other ECG markers to be of significance like T-wave alternance or heart rate turbulence. So at present, considering heart rate variability as a isolated marker is not advisable. Heart rate turbulence is defined by minute changes in ventricular cycle length following premature ventricular contraction, which is studied either in intracardiac pacing or with the help of an implantable cardioverter defibrillator. Heart rate turbulence is qualified by two parameters, that is turbulence onset and turbulence slope. Turbulence onset is the relative change in the RI interval caused by a PVC, and turbulence slope is the rate of change of RI interval back to baseline. With regard to sudden cardiac arrest prediction, heart rate turbulence has till now been the most extensively studied and has been shown to be a strong independent predictor of SCA. T-wave alternance is another parameter on ECGs which may predict sudden cardiac arrest. T-wave alternance is a bit-to-bit fluctuation in the amplitude of the T-wave as shown in this figure. There is only minute change in T-wave. Another ECGs which you can see is there may be more T-wave alternance which may predict higher chances of sudden cardiac arrest. So QT prolongation with T-wave alternance is a different thing. We are talking currently about T-wave alternance with normal corrected QT interval. So T-wave alternance may be detected in all patients at high heart rate, but it is of significance when it is present in patients with heart rate of less than 110 beats per minute. Previously, higher amplitude of T-wave alternance in microvolt T-wave alternance were found to be independent predictors, but it was later not demonstrated to be true as an isolated factor. So currently it may be useful in reclassifying patient who otherwise might be considered high risk for sudden cardiac arrest. So it has a very high negative predictive value in a patient of normal QRS, because in a patient with a wide QRS, T-wave alternance does not hold its significance. So patient having narrow QRS and unexplained syncope, and if there is no T wave alternance, then it is a high negative predictive value, but not as a high positive predictive value. Signal average electrocardiograms, which were initially thought to be very important and taken much frequently compared to current time. Signal averaged ECG is an amplified and processed ECGs that can detect abnormal microwave level potential not visible on a standard surface ECGs. These microvolt potentials are known as late potentials because they occur during the terminal portion of the processed QRS complex. Late potentials arise from the areas of slow conduction, which indicates delayed depolarization and probably scarred myocardium, which is a substrate for arrhythmia induction. The presence of late potential has been demonstrated to predict inducibility of VT at invasive electrophysiology study. In this ECGs, you can see that the normal surface electrogram is not very suspicious of having a scarred or delayed depolarization in the myocardium, but on the middle section that you will see that on signal average ECGs there is deflections and amplitudes at the end of the QRS after the QRS, which may represent delayed depolarization and substrate for ventricular tachycardias. Next point is T wave peak to T wave end. So more than 94 millisecond is considered to be high risk for inducibility of ventricular tachycardia or VF, as high T wave peak to T wave end represents longer ventricular repolarization and dispersion of ventricular repolarization, which leads to more propensity to develop ventricular fibrillation in a patient when they develop ectopics. So prolongation of this interval suggests increased susceptibility to re-entrant ventricular tachycardia. Longer TPE interval has been shown to predict VT, sudden death, or both in many populations with diverse characteristics including long QT syndrome, myocardial infarction, and Brugada syndrome. As you can see, T wave peak to T wave end, if it is more than 94 milliseconds, then it is considered to be of significantly prolonged T wave peak to T wave end duration and higher risk for sudden cardiac arrest. So till now we have seen all the ECG parameters, but when taken into isolation, those factors do not predict sudden cardiac arrest as combination of those factors may predict. So in a study of almost 7,000 patients studied for more than 10 years, they studied approximately 11 to 12 ECG predictors, and what they have found is that the factors which had a high weightage to be stratified for sudden cardiac arrest was, one is heart rate, resting heart rate more than 80 beats per minute, PR interval duration more than 220 milliseconds, QRS duration more than 110 milliseconds, LVH and T wave inversion, that is LVH with strain. So if the patient has more than or equal to 3 ECG abnormalities on the ECGs, they are at 10 times higher risk for development of sudden cardiac arrest compared to normal population. This is what we are talking about for normal patients and patients with LV dysfunctions. So the point for today's topic was that whenever a patient presents with unexplained syncope and you with structurally normal heart and you want to rule out whether the patient had a syncope of cardiac origin or not, these initial ECG waves and deflections may predict and may show that the patient must be studied for sudden cardiac arrest propensity and may well be stratified and treated accordingly. So we conclude for today's topic. These ECG parameters should be looked for, and so the threshold of suspicion should be high when looking at an ECG when evaluating a patient for syncope. Thank you.